I'm gonna go ahead and get started just for sake of time. Since it's 12, I think people are probably still joining, but. Okay. Right. So welcome, first monthly ECG rounds. So the goal is to do these, I'll start doing them once a month. And we'll probably cover 1 or 2 types of rhythms during each round. So they'll just be short 30-minute rounds that hopefully people can attend or won't be too long to listen to on your free time, just to review the different arrhythmias. So since it is our first one, we're first going to go over just some kind of normal background information, and then we'll be talking about atrial fibrillation. Okay, so just reviewing the normal conduction system of the heart, you can see this picture here. Normally the electrical activity originates from high up in the right atrium in the area of the sinus node. And then the electrical activity goes throughout the atria, down through the AV node, which is kind of in the middle part of the heart. And then it goes down through the bundle branches, into the Purkinje fibers, and then to the myocardium, or each myocyte of the ventricles. So what is an ECG? It is the recording of the heart's electrical activity from the surface of the body. And so it records changing potentials of the electrical field, and it only provides a rough approximation of the voltages generated by the heart. Initially, we'll just be talking about arrhythmias when we get into things like bundle branch blocks or things like that, or evaluating heart enlargement. Some of that you have to take with a grain of salt because it's only going to give you a rough approximation, and it can change depending on the position of the animal and body weight, all sorts of things. So the important parts of the ECG that you need to know in order to interpret a normal ECG, let alone any arrhythmias. The first part is the P wave right here. So the first little hump, and that P wave represents atrial depolarization. Then you have your PR interval, so basically the space from the beginning of the P wave to the onset of your QRS complex. And the PR interval represents AV nodal delay, so the time it takes that electrical activity to get through the AV node.
Yeah, I mean, it's definitely.
Then you have your QRS complex. So this is a negative Q, positive R, negative S. So kind of a completely normal QRS complex morphology right here, but that can vary a little bit. But the first negative deflection is always your Q, and your first positive is always the R wave. And the sum of the QRS represents ventricular depolarization.
Arising from.
Your ST segment is the space following the end of your QRS complex to the beginning of your T wave, and that represents ventricular recovery. And then your T wave is typically a positive deflection, but it can be negative in our patients. But the first deflection following the QRS complex, and that represents ventricular repolarization. It's important to know every QRS has to have a T wave. So sometimes we don't have P waves. Again, we'll go over different arrhythmias, but every QRS has to have a T wave. So you have to have ventricular repolarization. So recording an ECG, we have our bipolar leads, which are leads 1, 2, and 3. So bipolar means that they have one positive electrode and then one negative. So one positive pole and one negative pole. So lead 1 basically is going to be the lead between your 2 arms. So that's going to mainly be looking at your atrial, or be the best lead to look at your atrial activity. And then lead 2 and lead 3, and this nice little triangle that it makes up is called a Einthoven's triangle. And so when you're doing the just 3 leads, that's what a lot of like what our echo machine has, just like a 3-lead ECG. A lot of times you'll have a 4th lead as well. Oh, I guess I don't have it on here, which will give you your augmented leads, which allows you to have 6 full leads. So when you have the full 6 lead system, that gives you leads 1, 2, 3, AVR, AVL, and AVF, which are called your augmented leads. Again, your normal electrical activity for your heart. So it goes from the sinus node down through your ventricles. So normally the mass of the electroactivity is going down towards your left ventricle because your left ventricle makes up the major mass of your heart. And so if you're looking at lead 2, that kind of goes from down this angle. Your negative lead is, or your negative ends up here, your positive ends right down there. So that results in your positive deflection on the QRS complex. I can't see because this thing's in the way. So that results in the positive deflection on lead 2 for your P wave, your mainly positive deflection for the QRS and the T wave, because of that direction that the electrical activity is going towards the positive end of the lead. So recording an ECG, ideally the animal is placed in right lateral recumbency. And the electrodes are placed directly on the skin, what with electrode gel or alcohol. The electrodes are supposed to be placed distal to the elbows and under rather than over the chest wall, which will help remove baseline artifact from movement of the chest. So if you have the ECG lead electrodes too close to the chest or crossing over or on top of the dog and they're panting, it's going to be moving those leads, which will cause a lot of artifact on the recording you get, which a lot of times people overinterpret as fibrilation or things like that. So just be aware of what the patient's doing and try to minimize artifact as much as you can. The majority of the time you should view the tracing in lead 2 at 50 millimeters per second. So a lot of times I think the monitors like in the ICU might default to other leads. So always check lead 2. It just gives you the kind of the most normal recording that people are used to looking at. And so if it's on a different lead, it may look abnormal because it's not the normal lead 2 that you're used to looking at. And a lot of the ECGs also default to a paper speed of 25 millimeters per second, which is fine, but that's just going to make everything kind of bunched together. And so if you change the paper speed to 55 millimeters per second, it will help spread it out, which will help make it easier to see and easier to interpret, especially with our patients with their fast heart rates. And then you can adjust the gain on most of the monitors to make sure that the whole waveform is visible. As well as adjusting the tracing on the screen up or down. So this is the normal positioning for obtaining an ECG. And this would be a 6-lead ECG. There's 4 electrodes, but that creates all 6 leads.
I agree. I agree.
So we're looking at interpreting ECGs. The first thing we look at is these are kind of more nitty-gritty measurements, which I don't expect anyone to make but myself. But we're looking at the ECG paper. It's all standardized. So these little thin lines are 1 millimeter apart, and then the heavy lines are 5 millimeters apart. And so if you have the paper speed set at 50 millimeters per second, each of these little small boxes is going to be 0.02 seconds. And if you have it at 25, each of those little boxes is 0.04 seconds. And so speed is this way or times this way. And then amplitude or height is in this direction. And so each, if it's set at the gain is set at 10 millimeters per millivolt, which is kind of the standard gain, they should all be set there. Then each of these little boxes is 0.1 millivolts. So the first thing when we run an ECG or interpreting an ECG, it's important to know the heart rate. And so that will kind of take you down 2 different paths in terms of your differentials for an arrhythmia. So you have kind of tachycardias versus bradycardias are completely different differentials. So it's first important to know your heart rate. And there's a couple different ways to do that. One is you can count the number of QRS complexes in a 3-second period. If it's 25, if the paper speed is 25 millimeters per second, that would mean counting 75 of these small boxes. That equals 3 seconds and multiplying by 20. If the paper speed's at 50 millimeters per second, then you'd count 150 boxes and multiply by 20. Or you can do the cheating method, which is the big pen method. If it's at 50 millimeters per second, then a big pen, typically a standard big pen equals about 3 seconds. So that's kind of the quick, easy way to get a rough approximation of the heart rate if you're looking at a printout of an ECG. We don't always print out the ECG. If you're looking at the monitor, just keep in mind that the monitors are accurate to some degree, but sometimes they can misinterpret the heart rate. So sometimes if the complexes are really small, the monitors won't pick up on it, and it might say the patient's heart rate's like 0. Versus if it's like they have tall T waves, it might double count. It might count those T waves as QRS complexes, so it might be double counting the heart rate, or doubling what the heart rate actually is. So just keep that in mind. Easiest thing is to listen to the animal and get the heart rate that way too. Make sure it matches with the ECG. So then going through interpretation, things to look at. So after you know the heart rate, you can go down bradycardias or tachycardias, or if it's normal. And then things to look at. First, is there an upright P wave in lead 2? Is there a P for every QRS and a QRS for every P? Are the beats consistently and reasonably related? So if you have a P for every QRS and a QRS for every P, and they're always the same distance from each other, that means that they're related to each other. That means the conduction is coming down through the atria, going through the AV node, and then going through the ventricles as it should. Then are there any beats that are wide and bizarre, any extra beats or beats that look abnormal? So going over a normal sinus rhythm. So what is a normal heart rate? So for a normal sinus rhythm, the rate's going to be normal. So dogs less than 140, depends on the size of the dog and the situation. And cats typically less than 200. With the normal sinus rhythm, there will be an upright P wave in lead 2. There will be a P for every QRS and a QRS for every P, and they will be consistently and reasonably related. So that means that the PR interval, the distance between the P and the QRS complex, are normal and consistent. And are there any beats that are wide and bizarre? No. So the QRS complexes should be upright and narrow or normal looking. So this is a very typical normal sinus rhythm. So here are all your parts. You have your P wave, your QRS, and then it's hard to see the T wave in some of the images. But there is a T wave. Like I said, every complex needs a T wave. Here's a little T wave. And so this is a normal sinus rhythm, normal heart rate. You can see the P and the QRS are pretty consistent. So every QRS has a P wave, and the distance between the two is regular and normal. You will notice that there is some baseline artifacts. So like I said, you have to kind of know what your patient is doing. So most of these, like this right here, is just baseline artifacts. So if your patient is moving or panting or shaking, it's going to cause some of that little motion on the baseline, and that's just artifact, nothing to be concerned about. There's another normal sinus rhythm. So the heart rate is normal. You have your upright P wave, you have your QRS complex and your T wave. There's a P for every QRS and a QRS for every P, and the distance between the P and the QRS is normal and regular. So they're consistently related. Again, you have some little baseline artifact, little motion. And this, I'm guessing, I don't know who this was from. I'm guessing this animal was probably not positioned, might not have been positioned completely normal. That's why lead 2 looks a little bit different. Should look closer to lead 1. Okay, so if there's not any questions on normal sinus rhythm, we'll go over atrial fibrillation. And if there are questions, just unmute yourself and ask me, because I don't know where the chat went. I probably won't see it in the chat. Okay, atrial fibrillation. So with atrial fibrillation, there are multiple reentry circuits within the atrium. So if this is kind of a normal heart, so you have all these little reentrant circuits within the atria. So multiple little circular motion going around and around and around. And that results in a complete absence of coordinated electrical activity in the atria. And so the atria is not going to be contracting. So you lose your atrial contraction, which normally contributes about 20 to 30% of cardiac output. So you no longer have atrial contraction. What happens with all these numerous reentrant circuits is then they're bombarding the AV node, and the AV node can only transmit a certain number of impulses. And so it results that the rate in the atria is higher than the rate that the AV node is going to let through. And the AV node will transmit it at varying intervals. So it results in a very fast and a very irregular heart rate. And so typically the rate's going to be pretty fast. Over 200 beats per minute is most common. I did put a little asterisk here because there are some cases of what's called lone atrial fibrillation, where the heart rate will actually be slower. That's more common in large breed dogs like Irish Wolfhound. They're the main breed we see it in. Horses, it's pretty common. So there are some rare exceptions where you can have atrial fibrillation with a slow rate, but in most cases, the rate will be very fast and it will be irregular. And so when you're looking at ECG and going through those steps, first, again, you calculate with the heart rate. So the heart rate will be, like I said, fast, over 200 in dogs, over 250 in cats usually. Is there an upright P wave in lead 2? The answer is no. So atrial fibrillation, one of the most important things to remember is there are no P waves. So you do not have normal organized conduction through the atria, so you do not have a P wave. Sometimes you will see what are called fibrillation waves, which are like little baseline undulations, but you don't have to have that. So I think people often overinterpret those or assume that it's not AFib if they don't see those. But a lot of times in dogs, you actually don't see those fibrillation waves. And remember, if you have a dog that's kind of shaking, sometimes they might look like they're fib waves on the ECG if they're shaking or there's a lot of baseline motion. So I would the fib waves kind of take with a grain of salt, but that's probably one of the, if we're going through all the criteria, the least important criteria. One of the most important things, no P waves. And so if you're looking if there's a P for every QRS and QRS for every P, the answer is going to be no, because there are no P waves. And then the other important differentiating factor for AFib is that there are irregular RR intervals, or the distance between the QRS complexes varies. So there's no pattern to the rhythm, and I'll show you several examples. So like a sinus arrhythmia might vary a little bit, but it's predictable. But with atrial fibrillation, the QRS complexes are just all over the place. You cannot predict when the next one's going to occur. So like the RR interval might be long, and then it gets short, and then it gets even shorter, then longer again. And so that combined with the no P waves is kind of the character, the classic AFib. And then are there any beats that are wide and bizarre? No. So the QRS complexes should still look normal. So they should be upright and narrow like a normal sinus rhythm. It's just too fast, it's irregular, and there's no P waves. There are some exceptions, but we will not go into that today. So some examples. This heart rate is about 200 beats per minute, so heart rate is too fast. You're looking at P waves, there's no consistent P waves. So you might think like, oh, is that a little P wave? But you do not see it repeatedly. So no consistent P waves are present. Again, you can see these little baseline motions or fib waves may or may not always be present. The QRS complexes themselves look pretty normal. So they're upright and narrow. But then if you look at the RR interval, or the distance between each QRS complex, it varies. So these look kind of normal, and that was a little bit farther, and that was a lot farther, and it gets shorter again, and then farther, and then shorter, then farther, 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 shorter. So there's no rhyme or reason to when the next QRS complex is going to occur. This is another example of atrial fibrillation. This one's on treatment, so its heart rate is a little bit slower. So once they're on treatment for atrial fibrillation, their heart rate will not necessarily be fast. But again, looking at P waves, there's no consistent P waves. There is some little baseline fibrillation waves. The QRS complexes still look normal, so they're upright and narrow. But then if you look at the RR interval, or the regularity of the rhythm, it's very irregular. So farther apart, all of a sudden gets closer, then farther again, closer, farther, farther, a little bit closer, a little bit closer. So there's no predictability to it. Yet another example of atrial fibrillation. So again, the heart rate is, I didn't write down what the heart rate is, but the heart rate is fast. You could probably calculate, if anyone wants to count on their screen, you can probably calculate it. So the heart rate is fast. Looking for P waves, there are no P waves seen. You don't see any organized little positive deflections before the QRS complex, so no P waves are present. The QRS complexes still look relatively normal, upright. They might be a little wide, but they're still upright. And then again, the RR intervals are irregular, so that's pretty long, and then it gets shorter, and then long again, and shorter, and then longer here. So there's no predictability to it. Another ECG. So just note this paper speeds at 25, so it looks even faster because everything's kind of squeezed together. Looking at baseline, there's no P waves present. The QRS complexes are still fairly normal, upright, and narrow. And then the RDAR interval is irregular. So it kind of gets faster, then it gets slow, and then a little fast there, and it spreads out. There's no pattern. That's the classic atrial fibrillation. So when we see this, the treatment options are really rate control versus rhythm control. So rate control would be giving them medications to slow their heart rate so that it is closer to normal for them. Versus rhythm control is going to be converting them back to a normal sinus rhythm. In most cases of veterinary medicine, we're doing rate control. That's for a couple of reasons. One, if they have underlying heart disease, then even if you convert them to a normal rhythm, they typically do not stay in a normal rhythm. So if they have underlying heart disease, they're more likely to go back into atrial fibrillation. So rhythm control is not successful long-term. In most cases of AFib we see in our patients, it is because of underlying structural heart disease. So this is the main reason. So we're looking at rate control. The three options, as I taught, BCD, beta blockers, calcium channel blockers, and digoxin. So your main beta blocker is going to be atenolol as your pure beta blocker, but sotalol is also a beta blocker. If you're needing an IV option, there is also esmolol. Calcium channel blockers, we're mainly looking at diltiazem, and then your digoxin. So those are the three options for treatment of atrial fibrillation. Typically, we start with diltiazem first, but oftentimes they need both diltiazem and digoxin. So if you see a patient in the ICU or you're the nurse and you see that they're on one of these medications, that's the purpose of them, is just to slow down their heart rate so that it's closer to normal, which allows for better cardiac output. And yep, I think that's it. I guess I don't have an end slide. Any questions? That was close. Less than 30 minutes.
So prognosis depends on like the prognosis depends on just what the structural issue is with AFib.
For AFib, yeah. So typically they have significant underlying heart disease. So the prognosis is more based on the underlying heart disease, but the presence of AFib, like if you have a dog with DCM, the presence of AFib does worsen their prognosis long term. And so the prognosis with AFib in general, the better more adequate you can control their heart rate, the better long-term prognosis they have. So they used to say anything less than 160 was ideal, but there was a paper they did Holter monitors and on these dogs and found that an average daily heart rate of actually less than 120 to 140 was probably even better.
So like if you see a dog that's in AFib, like you'll do an echo and then you kind of give them at that point like prognostically what to expect.
Yeah. Yeah, and it's pretty common that if they have underlying heart disease, a lot of times once they go into AFib, a lot of times that will push them into heart failure, because when they go into atrial fibrillation, like I said, they lose that loss of atrial contraction, which contributes to 20–30% of their cardiac output. So they lose all that forward cardiac output, which often then pushes them into heart failure. So it's pretty common. You have a Doberman that all of a sudden comes in dyspneic and has a crazy high heart rate, and that's how they find out it has DCM, because it went into AFib. Then it's all like syncopal episodes when they first go to AFib, that kind of thing too. I think there might have been chats, but I can't see the chat thing. I don't know what. Any other questions? Maybe if I did this.
Hey, Kira. Can you hear me?
I can kind of hear.
Can you hear me now?
Yeah.
So I know a lot of these, like we were talking about, they have underlying heart disease, and that's what pushes them into AFib because their atria get big, and then they lose the kind of coordinated effort of the atria.
Yeah.
So is like once they're in AFib, are they likely to stay in AFib, like to the point where they're going to need medication moving forward? Or if you treat the underlying heart disease, can you sometimes get them out of AFib? Does that make sense?
Yeah, most of the time, most of our dogs and cats, once they go into AFib, it's usually persistent. They stay in AFib. So you give them medications that might decrease the rate, but they're still in atrial fibrillation. There are a couple cases where I've had them come back out of AFib, but that's pretty uncommon. So that's not usually what we set the owners up for. That is great if that happens, but that's not typically what happens. Usually they go into AFib and stay into AFib. Even if you treat their heart disease, you're not reversing like their atrial dilation, the fibrosis that's in atria. You're not reversing any of the changes that predispose them to the development of AFib to begin with, which is why we don't convert them to sinus rhythm, because we can, but then they usually come back out. They go back into AFib. The only exception is if you do have like a lone AFib case, those you could convert and they might stay in normal sinus rhythm. But most of the other cases, we're just slowing the heart rate. We don't expect the AFib to ever go away.
Cool. Thank you.
Yeah.
I have a quick question.
Yeah.
At what point do you want to try cardioconversion?
So that
With
would be if
AFib.
you're, yeah. So that would be if you're trying to convert them to a normal sinus rhythm. And the only really case we would do that is if it has low AFib. So if they have a normal echocardiogram or they have normal cardiac structure and function, they don't have underlying heart disease, that's when we would convert them to a normal sinus rhythm. Did I answer your question?
Yeah, thank you.
And we can convert them to normal sinus rhythm, either electrical cardioversion, or you can do medical conversion with medications. Like horses, they often convert with quinidine, and there are some medications we can use in dogs to convert them. But again, those are really cases of low AFib where they have a normal cardiac structure and function.
Why are thromboembolic complications not as common for dogs and cats? Because I feel like every other commercial that I see for heart meds in humans are like, blah, 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 get on this medication so you won't have thromboembolic complications.
Yeah, cats are like people. Dogs, thankfully, are not. So cats are at increased risk for thromboembolic disease. So with heart disease, and if a cat does develop atrial fibrillation, that definitely increases the risk even further for thromboembolic disease, because you again lose that atrial contraction. So you're gonna have very stagnant blood flow in the atria. Dogs do not. I don't think they actually know why. It's just dogs do not develop thromboembolic disease from heart disease or with AFib. Cats do. I'm sure there has to be a difference in their platelets, but I don't know exactly why.
Yeah. And I don't know, maybe I just don't see it, but I feel like I don't see as many cats in AFib as I do dogs. In my head, it's like, the Great Danes and the other big dogs, the Dobies that come in, you're like, okay, great, ACM, atrial fibrillation and DCM.
Yeah, so one of the main factors for the development of atrial fibrillation is going to be that the size of the atria, or just your overall mass, because it has to be large enough to sustain those reentrant circuits. And so if you think about the animals, we see AFib most commonly in larger breed dogs, because they have larger atria to begin with, and then if they have dilation on top of it, it makes it even larger. And if you think about horses, which is one of a common species we see lone AFib in, is because there's just the size of their atria to begin with is so large. Versus cats have a tiny little heart, and so it is less likely they're going to develop AFib because they don't have the mass or the size of the atria to sustain it. So typically if it happens, it's because they have severe left atrial dilation, and it is less common. We do see cases every once in a while, but it is less common than in dogs just because of their overall size.
Gotcha. Thank you. Makes sense.
If any of our zoo interns are on, I'd be interested. I don't know if they ever see AFib in like giraffes or elephants.
Yeah, I was wondering that as you were talking, like elephants, do they get AFib?
You think that they would? I don't know. I'll have to ask somebody. I've never read anything about it, but I would. Elephants. Those things, their size, like horses, get a lot lower AFib because they're just big, but I think like elephants, giant animals like that. Any other questions? I think that will be it.
I have a question. This is Becky. How do you do CPR on an elephant?
I don't know. Not successfully.
Yeah. Okay. Sorry, I just had to throw that in there since we're talking about elephant heart problems. I was just imagining blowing in its snout or something. Its trunk.
Yeah, I think at that point there's no option.
Yeah.
Sadly.
Thank you, Kira. This is great.
Yeah, it was really good.
No problem.
you.
Bye. Oh, there's a chat.
I was wondering,